Hello, Insta family. It is Dr. T here, and I've got to tell you, I feel like I have been away for a really long time. I haven't let anybody know that I'm hopping online tonight, but I thought that I would just jump on here, see who's out there, see who wants to jump on and ask me any questions. I have had a bit of a hiatus from social media for the last month, and I must say I missed you guys. Did you miss me? I hope so. I had an amazing birthday. Thank you so much to everybody for the incredible well wishes. I'll make sure I send some photos. I had an incredible trip to the Maldives and shared with you guys some amazing messages, some inspirational things that I kind of learned in just having some time to sit and breathe and do a bit of nothing. But I'm back. I am back, and I'm back with a vengeance because it's time to get back on the education and the women's empowerment pathway. And so I thought, look, I'm just going to randomly jump on Wednesday night like I always do and see who's here. Now, I have had a question dropped into the comments, but just a reminder to everyone, you can drop some short questions into the comments. Don't need your whole life story. Be as generic as you can. I'll give some generic answers, short and sweet. And if I don't get to your questions tonight, feel free to send me a DM and I will answer them next week. Now, Chantel, not a question, but I saw you at Monash when I was there during my cycle. Oh, it was like seeing a celebrity. How about the fact that I was probably working? But lovely to have you drop into the comments, Chantel, and I'm really hoping that your experience has been a good one. That's what we aspire to at Monash IVF, top quality experiences. But does anybody have a question? Oh, lovely to see some of you here. Life of Brit's on. Who else is on? Court Butler, Amy Colton, hello. Alicia Tinker, Melanie English. Hey guys, lovely to see you on. So, no one has, Hayley B2790. Just wondering if you consider an AMH of 3.4, I'm guessing that's 3.4 picomole per litre. That's the measurement that we use in Australia. In a 34-year-old, really low, would you say IVF can still be promising if my bloods show I ovulate? Okay, let's talk about ovarian reserve tests. So the two ovarian reserve tests that we kind of rely on to measure how many eggs you got left in your ovaries is the AMH or anti-Mullerian hormone, which is a blood test, or the antral follicle count, which is where you count the number of follicles of a certain size on the ovaries. Now, here's the tricky thing about the AMH. It is falsely suppressed by the pill. So if you're on the oral contraceptive pill or have been in the last 3 months, you will find that it will lower the AMH result. Why is that? Well, when you go on the pill, your ovaries kind of go back to sleep. In fact, if you did an ultrasound on the pill, the ovaries would look quite small, and the follicles stay in their primordial size, which is smaller than an antral follicle size. So it's really important to make sure that you get, if your AMH is low, I would absolutely recommend you get an antral follicle count. If you have been on the pill in the last 3 months, then I would absolutely recommend that you repeat the AMH, because coming off the pill, it normalizes it over a period of about 3 months. So there are two things to consider. Now, in answer to your question, would I consider an AMH of 3.4 at 34 low? Yes, I would. And that's why I would want to correlate it with the antral follicle count. The AMH and the antral follicle count are not a measure of your fertility. So your fertility, or your ability to conceive, is more commensurate with your age, and being only 34 and your eggs being good quality at 34, unless there's something else going on, then probably if you had timed intercourse, you would be able to conceive, no worries. If you did IVF, you would probably be able to conceive as well. You just won't collect very many eggs, but by rights, the eggs will be of excellent quality. Where IVF would benefit someone with a very low ovarian reserve at 34 is the ability to future-proof by banking embryos. So you can create multiple embryos by doing a few cycles. You probably won't get enough out of just one cycle, but you could bank embryos and therefore future-proof, if you wanted more than one child, future-proof yourself. Because the thing is, even if you were to conceive straight away, you've still got 9 months of a pregnancy, you're still probably going to breastfeed it, you probably want to get it out of nappies and maybe sleeping through the night before you might want to have a second child. And it may be that the AMH or antral follicle count has declined so much that in your late 30s, you might not have that opportunity. The other thing about a low AMH in your early 30s is that there's a fair chance that you're going to experience an early or a premature menopause as well. So they're the sort of ways that we would use those ovarian reserve tests. But the main thing that you need to understand is that your fertility is likely to be good unless there is something else going on, because your eggs are of great quality at the age of 34. So I'm hoping, Hayley B, that has been a helpful answer, and I wish you all the best of luck. Now, I can see a few other people on here. Sarah Kelly's here, Joanna Henderson, Cara, Rach Perry, Pilates is on. Fantastic, Hayley. Good work. I love the way you're taking your fertility and your family planning into your own hands. That's fantastic. Okay, are there any other questions that anybody else wants to ask? That's an excellent question to ask. And I often get asked, what is the AMH? What is the antral follicle count? What does it have to do with my fertility? So hopefully that was a helpful answer to others who are out there. I had a really interesting consultation the other day with a woman in her early 40s who had a low antral follicle count and AMH. And we were talking about the fact that, again, her fertility wasn't so much dependent on her egg count as it was dependent on the quality of the eggs. So unfortunately, by the time a woman actually hits the age of 40, about 7 to 8 out of 10 of her eggs are going to be chromosomally normal. So if she's only producing sort of less than 5 eggs in a cycle each month, then there's a fair chance that all of them, or sort of 4 out of 5 of them, are going to be abnormal. So, it gives you very little opportunity to easily fall pregnant if you are simply timing intercourse and relying on the fact that the body is releasing the normal egg, when in fact, out of the 6 or 5 eggs, it could be one of the 4 abnormal ones that is actually released. So even someone with a low count when they're older, they're going to have a far greater likelihood of falling pregnant by performing IVF and giving every egg that is released an opportunity to be fertilized, and therefore potentially making a baby. Any other questions? Gosh, everyone's just patiently waiting for someone else to ask a question. Any other questions to ask? Let me see. Oh, the Fertility Doc's on. Hello, hello. The Finders Collective, lovely to have you. Francesca is on. But no more questions. Now, what else could I potentially talk about? Let me see. Let me talk about tubal patency testing, because I had a discussion with someone the other day about testing of tubal patency. So I actually did a procedure tonight on a patient using laparoscopy and watching the passage of dye pass through the tubes at laparoscopy. That would be considered the gold standard. So laparoscopy and dye chromotubation. The other two tests that we'll often do is either an HSG, so a hysterosonogram. That's an X-ray where you go into an X-ray department and a radiologist passes contrast through the tubes and literally takes an X-ray, and you can get not only the outline of the uterus, but you can also see the dye spilling into the abdominal cavity. That's also helpful for things like polyps or say a bicornuate uterus, showing the sort of the septum in the middle, also showing submucosal fibroids. So there are some multiple benefits to an HSG. The alternative is something called an hycosi. So that's where, using ultrasound, we pass often agitated fluid, often agitated saline, through the cervix, through the cavity, and through the tubes. And so it's more of a dynamic test. You're actually watching it fill the cavity and also actively spill through the tubes. That's performed by a sonologist in the ultrasound department. The benefit of ultrasound is you can go and look at other things at the same time, like you can look at antral follicle count, you can look for signs of endometriosis or cysts, and you can also look at any uterine anomalies such as fibroids or septums or so on. But they both ultimately do demonstrate tubal patency. Both tests can be a little uncomfortable, so I would always warn someone who's going to get a tubal patency test to take some anti-inflammatories and Panadol prior to going, just to reduce the chances of cramping afterwards. So yeah, hopefully that's helpful to anyone who is looking at doing a tubal patency test. One other tip, they will only allow you to book these tests in the first half of your cycle, or if you are on contraception, because the worst thing would be is if you had ovulated, had unprotected sexual intercourse, you were in the early stages of pregnancy and you didn't know, and then they flushed an embryo out of the tubes. So that would be a really bad idea. So you have to be at the correct time, the first half of your cycle, in order to have a tubal patency test. All right, Alicia Tinker, how long after removing an IUD with known endo and adeno would you recommend further testing with no successful pregnancy? Oh, absolutely 6 months, no longer, because adeno and endometriosis are progressive diseases. So if you're having regular ovulatory cycles, then the chances of progression or recurrence of your disease is high. So I would give you no more than 6 months of trying for spontaneous conception before seeking assistance. Absolutely. Okay, hopefully that was helpful. Liana Barakloff. Quick tips on increasing your egg quality during a couple of months rest. Quick tips, egg quality. Oh gosh, I got to tell you, if I had the magic pill, I'd be a millionaire. But some of the things that are currently at the top of the list of adjuvants that we would use for egg quality would be coenzyme Q10, melatonin, MNM or nicotinamide or NAD+, you might see them. They are all sort of antioxidant preparations that are thought to be part of the electron transport chain, which helps to improve the health of the mitochondria and therefore the health of the egg. It's also about that intrafollicular environment, so an androgen therapy, either DHEA over a longer period of time, or just testosterone. So Andropheme is the drug that I often prescribe, testosterone for females. And it's about sort of bathing those eggs in that substrate because the cells require androgens in order to create estrogen. And so if you've got that nice environment where the egg is growing up, then that is thought to improve quality. But apart from that, to be honest, I wish we knew. I really do. Obviously, growth hormone has been tested. A big randomized multi-centered trial showed that it was unhelpful in a poor responding older population. Yeah, that's kind of it. I'm sorry, there's not much more that we can do to improve egg quality. Hello, Michaela Pike, Miss Penny, Shaya Love, Zara, Astrid, my pleasure. Any other questions? One last question and then I'm going to wrap it up. And if no one's got a question, Kobe May, hello there, Stefan. I'll wrap it up by saying have a beautiful rest of your week. I know that it is Mother's Day this Sunday, and I know some of you are aspiring mothers, and I want you to wrap yourselves in a beautiful warm blanket, have a cup of tea, be kind to yourself, do something to fill your cup, and make sure that you take care of yourself this weekend, no matter what. Hayley B, one more question. I promise I won't hog anymore. Oh, you can hog as much as you like. Do you have any advice on coffee granule-like periods? Coffee granule-like periods? That sounds very odd, my friend. It doesn't sound like a nicely shedding lining. I would be interested to know what your ovulatory cycles are like and what your lining looks like in the middle of your cycle. So yes, coffee granule-like periods doesn't quite sound normal to me. Cara, can you breastfeed during a transfer protocol? Oh, Cara, I could spend all night talking about this. Look, I'm one that would not recommend low dose stimulation FET cycle whilst breastfeeding because we're kind of relying on the follicles to produce the hormones to build the lining up to then put the embryo back in. However, in saying that, I have recently been in contact with a colleague at my sister clinic in Repromed who is doing a lot of research into breastfeeding and embryo transfer cycles. And it doesn't appear that if you have a normal, regular ovulatory cycle despite breastfeeding, it doesn't appear that the pregnancy rates are any less affected. But I would probably be going more for an HRT FET cycle in that context, just because of that risk of disordered ovulation in the context of breastfeeding. I think we'll wrap it up there. For a spontaneous jump on a Wednesday night, I really appreciate the fact that everybody has contributed. Everyone's had some great stories and some great questions. And I will catch up with you guys next Wednesday night. See you later.